Dr. Robbie Erskine and Dr. Ben Fox, thank you so much for joining us on another one of these RA UK 21 5-minute interviews. How are you both doing?
Great. Thank you. Thank you, Amit.
And Robbie?
I'm great. Thanks, Amit. It's a real pleasure to see you, and thanks so much for inviting us. Fantastic.
Well, we're really getting close now to D-Day. 5th and 6th of May is just around the corner. So I thought this would be a great opportunity to ask you both in turn why you're excited about RA UK and why your session is going to be one of the sessions not to miss. So why don't we start with you, Ben?
I'm just told to turn up, basically. I'm joking. I'm super looking forward to it. I mean, as you were just saying before the recording, our delegates for this meeting are fantastic. It's the biggest meeting that we've ever had. So that in its own way is something to be excited about. But also it's the combination of all the different areas which can involve an ultrasound machine. And you've got so many fantastic speakers. Robbie's brilliant, knows everything about spinal anaesthesia. So I'm quite looking forward to his half of this talk.
Robbie?
Well, I mean, it's just a fantastic setup you've got. I mean, it's so exciting. I mean, I've been in regional anaesthesia for 30 years now, and just to see, from being a rather sort of quirky little guy who did all these regional blocks years and years ago, always a bit weird, that Dr. Erskine, he does all this funny stuff and these funny spinals and stuff. And it's just moved on. And you guys, through Regional Anaesthesia UK, when it was with the Irish group, wasn't it, originally, as a sort of little arm of Europe. And now you've moved it forward, you guys, you and Mornay and everybody have moved it right forward into the 21st century. And it's just so exciting to be part of that. Having been into it for so long, and it's just amazing what you've done and how you've taken it forward. You raised the profile, and it's just a great opportunity. And all the people come from the States to attend, and Europe, and it's just amazing, absolutely amazing. Well done. Very exciting.
I mean, the meeting is only a success because of speakers like you guys, and we need people like you to make it happen. So I'm really interested in your spinal symposium. So what is it that's going to be exciting and different? What are people going to get if they listen to that spinal symposium? What are they going to be their take-home points? What are they going to learn from that?
After you, Ben, you first.
Are you sure?
Go.
So I think it's going to be a nice mix in that it should cater to the people that are just starting their journey or already starting their journey for same-day spinal anaesthesia. So it will cater to that side of things, but also it's going to cater to the people that are really kind of pushing the boundaries. And we're talking about same-day hips, same-day knees, and the really kind of cool, fun stuff that Robbie's currently doing at the moment. And then we should try, we're going to make it fun as well. So
Robbie, anything you want to add to that?
Yeah, I mean, I know people sometimes think maybe spinal anaesthesia isn't as sexy as ultrasound guided regional anaesthesia, you know, but let's face it, it's the non-regionalists regional, isn't it? It's the ultimate regional that everybody can do, and that's really exciting. We can all do it, but I think we just need to do it just a bit better, just be more focused, be more targeted. And I think you guys are already doing this with all the regional anaesthesia. You're targeting it now. We can see what we're doing. We get closer to everything. It's more focused. We're thinking about what we do. We're not just blocking half the body and just forgetting about it for a week. So I think regional anaesthesia and spinal anaesthesia go hand in hand like that. And certainly, I think it's the focused approach which I'm trying to look at now. Everybody should have a day case spinal. If they're going to have a spinal, it should just suit the procedure and the patient. And that's the exciting thing, and that's what I want to take forward.
Well, I think the thing that I'm most looking forward to learning is just how to refine my technique and learning those little nuances that have now become so routine for you. Something just to take my regional anaesthesia, my spinal anaesthesia to the next level. So for me, I'm very much looking forward to learning lots from your session. Now, gents, you've watched a few of these videos, so you know how the video ends every time. You know the ending. So I'm going to ask you, each of you, those 3 questions. We can do it a block at a time, and you each have a go first. So I want you guys to name your favorite upper limb block, your favorite lower limb block, and your favorite trunk block. So we'll start with upper limb. Dr. Fox, what's your favorite upper limb block?
I like a cervical epidural. It's my go-to for killing people. No,
Yeah.
you're recording this as well, so I shouldn't have said. No, I'm an interscaling man. I think it was a while ago. I was like first year consultant, and I was grabbing onto all the kind of fancy new blocks. And problem is that when you got new trainees with you, you want to get them up to speed with the basics. So I've changed my practice quite a bit, and I tend not to do too much that's fancy. So interscaling for shoulders.
Okay, Robbie, Dr. Erskine, what's your favorite upper limb block?
Well, there's a question now. Yeah, if you're talking what the block that I've done the most of in the last 15, 20 years, which does everything I want to do from anywhere just above the elbow right down to the hand, has got to be hands down, if you pardon the pun, the axillary block. I mean, it is, what is it? It does everything you want. It is simple. It is great to teach, fantastic for teaching trainees to needle position and needle guidance. There's very little from the complication point of view that you can cause. When anything even infraclavicular blocks can be a bit of an issue. There's always a potential for complications there. I think axillary blocks are just incredibly safe. They're incredibly effective and great to teach, and they do so much and can achieve so much. And it's one of the Plan A blocks, of course, like Ben's. So I think that's definitely my favourite.
Okay,
transformed by ultrasound. If you remember, 30 years ago, we avoided them because they just didn't work very well. So we always went for supraclavicular blocks. And if you look at the history of it, suddenly ultrasound came in. I started using about 17, 18 years ago, and bang, axillary, suddenly it becomes the block to do. So for me, yeah.
It's a real joy to teach, isn't it? When you see somebody finally get it. Absolutely. Okay. So now we're going to move to lower limb. Dr. Fox, give me your safe, non-controversial lower limb block choice.
Wait for it.
My femoral. I just love femoral. I really like femoral for just fractured hips. It's a really nice block to teach. Yeah, I'll go with that. Yeah.
Okay. Robbie.
Well, there's a one. I was thinking about this today, actually, and having taught 4 of them today, I've got to say, and it's not been mentioned much, I don't think, the IPAC block. Now, for me, the IPAC block has been the biggest game changer for knee analgesia for total and uni knees in 25 years. Wow. It's been my absolute savior. It's just the most amazing block. It's very, very easy to do. It's a sort of fascial plane block, really. Very simple, very quick, single injection. And it is really, really effective. And when you're doing day case knees and stuff like that with short acting spinals, you need good follow-on analgesia to take over, and it's an absolute dream. Obviously not on its own, but if I had to pick one, let's say IPAC. Why not? There you go.
Okay, so I think you're in good company. If memory serves correctly, I think Steve Haskins picked that as one of his, but I think he cheated. I think he had a combination femoral triangle and IPAC, but you guys stuck to the rules. That's good.
Well, I'm in good company then, and I'll stick to one block, and it's an IPAC.
Perfect. Yeah. And so to close off our session, we're going to talk about trunk blocks. So we all know there's been a massive explosion of trunk blocks, lots of new, but there's certainly lots of old blocks. So Dr. Fox, if you had to pick a trunk block, what would you go for?
I don't know if this is outside of the scope, but I would say intrathecal diamorphine for any major abdominal surgery.
It's a fair play. It's in keeping with the with your symposium as well. So, and you're going to stick with that. You're happy with that choice?
Yeah, I'm happy with that. If I was on a desert island, I'd like a needle with some diamorphine.
Okay, Dr. Erskine, your favourite trunk block of choice?
Well, you see, now I'm going to be really old-fashioned. You think, who is this old git? but I'm going to say a thoracic epidural.
I knew you were going to do that. I knew you were going to do that.
I'm so sorry. I've been a vascular anaesthetist as one of my little things for getting on for 25, I don't know how many years. And it has always served me absolutely wonderfully over the years. I think the key with epidurals is, I know there's a lot of controversy about it, but the key is to really, really focus on getting it right. Make sure it's working before you start. Really, really, really concentrate on it. And your failure rate goes right down. We audit this regularly in our hospital, and we do far less than we used to. And I know Steve Coppins, I was talking to him about this. He says the more you do, the better you get. But actually, I think we do far less. But we decide really carefully who we do them on, and we make sure we do them properly. And I think it's just the most amazing block. Sorry, I know it's a bit old-fashioned and probably not what everybody would say, but that's my view. So,
well, there's no doubt. If I think back to probably one of the most formative parts of my training, other than regional anaesthesia, is when I did the liver transplant job, and when we used to do the hepatobiliary work. Thoracic epidurals in that group, that was probably when I did the most of my career. I was blown away by how effective they can be. So
yes.
I think I'm going to have to give you both those slightly atypical but very valid answers. So excellent. Listen, guys, thank you so much for spending time to chat to me during your busy lives and in the run up to RUK. I really appreciate it. Look forward to seeing you both during your symposium. And thank you so much again for being part of our meeting. We hope it's going to be a great success this year. Thank you so much for your time. Take care, guys.
It's been a joy. Thank you.
Cheers. Thank you. Yeah.
Bye-bye.
Thanks, Amit.
Bye-bye.